In this image in front of you, it shows evidence of ring-enhanced brain lesion. Is it a high-grade glioma, a metastasis, or an abscess? This is one of the most common dilemmas in neuroradiology. Today, we use magnetic resonance spectroscopy to find the definitive answer. Glioblastoma and the peritumoral zone. Key point: high choline, low Na plus due to infiltrative edema. The secret is in the voxel placement. In GBM, the choline peak remains elevated even in the peritumoral edema because the tumor is infiltrative. Metastasis, the vasogenic difference. Key point: high choline in the core, but normal spectra in the edema. Unlike GBM, metastatic edema is vasogenic. If you see normal spectroscopy outside the enhancement and inside surrounding edema. Think metastasis. Infection, the signature peaks. Key point: amino acid peaks at 0.9 ppm. Abscesses have a unique chemical signature. Look for valine and leucine peaks at 0.9 ppm. If you see these, it's an infection, not a tumor. Normal peaks of metabolites. Lipids resonates at 1.3 ppm. Lactate resonates at 1.33 ppm. Alanine resonates at 1.48 ppm. N-acetylaspartate, Na resonates at 2.0 ppm. Glutamine glutamate resonates at 2.2 to 2.4 ppm. GABA resonates at 2.2 to 2.4 ppm. 2-hydroxyglutaraate resonates at 2.25 ppm 6. Citrate resonates 2.6 ppm. Creatine resonates at 3.0 ppm. Choline resonates at 3.2 ppm. Myoinositol resonates at 3.5 ppm and 4.06 ppm. Water resonates at 4.7 ppm. When you are facing with a ring-enhanced brain lesion, the MR spectroscopy can differentiate between lesions as follow. In case of glioblastoma, there is high choline, low acetyl aspartate and infiltrative edema. In case of metastases, there is abnormal high choline in the core with normal spectra in the surrounding edema. While in case of abscess, there is high lipid, lactate and amino acids with low choline. Which of these cases do you find most difficult in your daily practice? Drop a comment below. If you are on call as a resident at 2 a.m. A 2-year-old presents with a large, palpable abdominal mass. You open the CT, and you see a massive, heterogeneously enhancing lesion. Your report will decide the next step: surgery, biopsy, or immediate oncology referral. Making the wrong call here changes everything. Is it a neuroblastoma, or is it a Wilms tumor? Today, we are going to make that choice simple. The first question you must ask is, where did this start? Wilms tumor is a renal tumor. It arises from the kidney parenchyma. Look for the claw sign. This is the thin rim of normal renal tissue that appears to claw around the edges of the tumor, arrow. If you see the claw, you are looking at Wilms. Neuroblastoma, however, usually arises from the adrenal gland. It's an extrarenal mass that displaces the kidney downward and outward. If the kidney is intact but pushed away, think neuroblastoma. Growth patterns: encasement versus displacement. Now, look at the vessels. This is the master key for residents. Neuroblastoma is a stealth grower. It is infiltrative. It likes to encase the aorta and the SMA, wrapping around them without necessarily narrowing the lumen. It crosses the midline frequently. Wilms tumor is an expansive grower. It acts like a giant balloon. It pushes the vessels, the liver, and the bowel out of its way. If you see the aorta pushed to the opposite side but not surrounded, that points toward Wilms. This smart art revealed the growth pattern in case of neuroblastoma where it encased the aorta and or superior mesenteric artery without necessary lumen narrowing. While in case of Wilms tumor acts as giant balloon, if you see the aorta is pushed to the opposite side but not surrounded, that points toward Wilms. Don't forget the calcifications. On CT, neuroblastoma is calcified in up to 90% of cases. We are talking about coarse, stippled, or cloud-like calcifications. In Wilms tumor, calcification is much rarer, occurring in only about 10 to 15% of cases. If it's heavily calcified, it's a neuroblastoma until proven otherwise. Let's summarize your reading room checklist. 1. Origin. Intrarenal with a claw sign. Wilms. Extrarenal. Neuroblastoma. 2. Vessels. Encasement and crossing the midline. Neuroblastoma. Displacement. Wilms. 3. Calcification, present and coarse. Neuroblastoma. 4. Age, both peak around age 2 to 3. But neuroblastoma can appear much earlier in infants. Remember, catching these signs early is what separates a good radiologist from a great one. If you found this differential helpful, check out my other lecture on ganglioneuroma versus ganglioneuroblastoma to complete your pediatric oncology knowledge. What's the most challenging pediatric mass you've seen lately? Let's discuss it in the comments. I'm Dr. Mohammad El-Masri, and I'll see you in the next reading.
Imagine a patient presents with progressive hearing loss and a hint of facial numbness. You look at the scan, and there it is, a mass in the cerebellopontine angle. It looks like a classic vestibular schwannoma, right? But what if the internal auditory canal is normal? What if it's a diagnostic ghost hiding a more aggressive pathology? Today, we aren't just looking at scans. We're solving the case of the silent angle. The clues is vestibular schwannoma versus meningioma. Story is walk through the most common suspect. Key teaching points. Focus on the ice cream cone sign versus the dural tail. Show the widening of the internal auditory canal, IAC, as the smoking gun for schwannoma. Clinical pearl. Mention that schwannomas usually center on the internal auditory canal, while meningiomas are often eccentric. The plot twist. The epidermoid, wolf in sheep's clothing. Just when you think you have it narrowed down, you see a lesion that looks like cerebrospinal fluid on T1 and T2. Is it an arachnoid cyst? Not so fast. Key teaching points. Introduce diffusion-weighted imaging, DWI. Show how the restricted diffusion reveals the epidermoid cyst, but if it is free diffusion, it will be arachnoid cyst. Cerebellopontine angle masses can be summarized in the following smart art. The most common lesion, which is vestibulocochlear schwannoma, followed by meningioma, epidermoid, and arachnoid cyst. In addition to cholesterol granuloma, differentiation of these lesions are mentioned in smart art. In radiology, the story is in the details. Don't let the CP angle remain a mystery. If this case helped you, subscribe for more neuroradiology deep dives.
50-year-old male. History of migraines, new onset seizure. The imaging reveals a well-defined lesion in the right frontal lobe with some hazy enhancements. The emergency doctor says, brain tumor. But as a neuroradiologist specialist, you look closer and you see something else. A popcorn-like texture with a dark hemosiderin rim. It's not a tumor. It's a vascular trap. If you treat this like a tumor, you could make a catastrophic mistake. Today, we are diving into the differential diagnosis of vascular brain lesions, the hidden mimics. Popcorn in the brain? Differentiating vascular brain lesions. Arteriovenous malformation. Cavernoma. Developmental venous anomaly. Cavernous malformations or cavernomas. These are low-flow, benign lesions. They look like a pile of popcorn because they are clusters of small, thin-walled blood vessels filled with blood at different ages. This patient often presents with epilepsy or focal deficits, not massive stroke. MRI with gradient susceptibility imaging is our best friend here to find that dark hemosiderin ring. The caput medusae, developmental venous anomaly. Next up, the developmental venous anomaly, or DVA. Think of this as the caput medusae, or a palm tree appearance. Key point, this is a variant of normal venous drainage. Do not surgically remove a DVA, or you will cause venous congestion and a stroke. They are often innocent bystanders. The high-flow AVM, arteriovenous fistula. Unlike low-flow cavernomas, EVFs are high-flow emergencies. Abnormal arteries directly feeding veins without a capillary bed. This is the patient who presents young, with an intracranial hemorrhage. The differentiator? Pulsation artifacts on MRI or angiography showing feeding vessels. Arteriovenous malformations, AVMs, are characterized by an abnormal leash of vessels allowing for arteriovenous shunting. They can occur anywhere in the body but are most common in the brain. There is direct arteriovenous communication with no intervening capillary bed. They can be congenital or acquired. T2 axial imaging demonstrates numerous serpiginous flow voids consistent with a very large right-sided arteriovenous malformation, AVM. Key takeaways for the video content. Definition: a vascular lesion is a snarled area in blood vessels that disrupts normal blood flow. Types: AVMs, cavernous malformations, venous malformations, telangiectasias. Symptoms: headache, seizures, neurological deficit, bleeding. Causes: mostly developmental processes during fetal growth, but some are acquired, like DAVFs. Diagnosis: MRI is best for characterizing these lesions, often looking for a popcorn appearance in cavernomas or caput medusae in venous malformations. Treatment depends on size and location, can be monitored or treated with microsurgery, gamma knife, radiosurgery, or endovascular embolization. Finally, this smart art can give us a summary of types of vascular brain lesions which include capillary telangiectasia, angioma, developmental venous anomaly, dural AVF and AVM.
It's 2 a.m. You've just finished a long list when the pings you. A 45-year-old patient, severe generalized abdominal pain, guarding, and a high white cell count. The clinical question? Just 2 words. Acute abdomen. But acute abdomen isn't a diagnosis. It's a mystery, and in the next few minutes, we are the ones who have to solve it before the patient heads to the OR. Welcome to the race against time. When the pressure is on, you can't rely on luck. You need a system. I group my acute DD into 4, must not miss, buckets. In case of acute abdominal pain, my strategy is as follows. I have 4 sites first to be examined, which are the right upper quadrant to prove or exclude acute cholecystitis, left upper quadrant for gastric lesions, right lower quadrant mainly for acute cholecystitis, and finally to left lower quadrant for sigmoid diverticulitis. This is a single CT axial image with acute cholecystitis. Note is made of pericholecystic fluid, gallbladder wall thickening and a gallstone in the gallbladder neck, as well as other non-obstructing calculi, findings that are consistent with acute cholecystitis. This is a single CT axial image of perforated gastric ulcer revealed a focal luminal outpouching with surrounding fat stranding along the lesser curvature of the stomach. No free air or free fluid. CT axial image in the right lower quadrant revealed a subhepatic collection containing gas and appendicolith, in keeping with an appendicular abscess. CT axial image in the left lower quadrant revealed perforated sigmoid diverticulitis. If these 4 quadrants are free from lesions, my second step is screening the whole abdomen, searching for one of the following signs. I have a mnemonic for these signs, which is BIFI, which B correspond to bowel wall thickening, I for inflamed fat, F for free fluid or free air, and finally another I for ileus, in case of inflamed fat, which can points to the site of the lesion, while bowel thickening if seen in small bowel probably will be inflammation, while if it is in large bowel will be mostly tumors. The ileus could be obstructive or paralytic, while presence of free air or free fluid points towards perforation.
Contrast coronal CT images demonstrating prominent and increased mesenteric vascularity representing comb sign and small bowel wall inflammation at multiple levels suggestive of Crohn's disease. Diagram illustrates differences between the CT appearance of normal fat, fat stranding, peritoneal and/or fascial thickening, and free fluid. This smart art divides the ileus into 2 types. The first one is obstructive, which could be diagnosed by presence of parts of bowel dilated and the other parts are not dilated, as in volvulus, while the second one is paralytic type, which shows dilatation of all bowels, as in peritonitis. On CT there is evidence of an encapsulated fluid causing subacute bowel obstruction. The transition is seen at proximal ileal level. No abrupt transition seen. There is a large volume of free subdiaphragmatic gas with air fluid levels under both hemidiaphragms. Here's my pro tip for the night: always look at the lung bases on an abdominal cort. I've seen residents spend 20 minutes hunting for an abdominal cause of pain, only to realize the patient has a massive lower lobe pneumonia. The acute abdomen can sometimes hide outside the abdomen. Mastering the DD of the acute abdomen is about speed and system. If you want to dive deeper into these specific cases, check out my Radiology Know-How playlist. Don't forget to subscribe to help us grow our AI radiology community. I'm Dr. Mohammed El Masri, and I'll see you on the next shift.
Welcome back. Today, we have a diagnostic challenge that every radiology resident must master. Look at this 6-year-old child presenting with ataxia and signs of increased intracranial pressure. We see a large, heterogeneously enhancing mass centered in the 4th ventricle. Before we dive into the lecture, I want you to look closely at the growth pattern. Is it arising from the roof or the floor? Is it squeezing through the foramina? Pause the video and leave your initial diagnosis in the comments: medulloblastoma or ependymoma. Let's break down the big 2. While both occur in the 4th ventricle, their personalities on imaging are very different. Location. Medulloblastoma typically arises from the roof of the 4th ventricle, the superior medullary velum, whereas ependymoma usually arises from the floor. This is your first major clue. Diffusion, the secret weapon. Medulloblastomas are highly cellular. This means you will almost always see restricted diffusion, bright on DWI, dark on ADC. Ependymomas are generally less cellular and won't show that same degree of restriction. Calcification. If you see prominent calcification on CT or susceptibility-weighted imaging, think ependymoma. It's much more common there, about 50%, than in medulloblastoma. It's not always a 2-horse race. We must consider the mimics. Juvenile pilocytic astrocytoma, JPA. Look for the classic cyst with an enhancing mural nodule. Unlike our mystery case, JPA is usually more lateral in the cerebellar hemisphere and lacks restricted diffusion. ATRT. This is the aggressive cousin. If the patient is very young, usually under 3 years old, and the tumor looks like a medulloblastoma but is even more heterogeneous with eccentric cysts, you must consider atypical teratoid/rhabdoid tumor. Here are your clinical pearls for the report. The plastic sign. Ependymomas are soft tumors. They don't just grow, they mold and squeeze through the foramina of Luschka and Magendie. If you see tumor extending into the cerebellopontine angle, it's almost certainly an ependymoma. Surgical planning. Always tell your neurosurgeon if the tumor is attached to the floor of the fourth ventricle. That's where the cranial nerve nuclei sit, making total resection much more dangerous. The spine. Never forget, if you suspect medulloblastoma, you must recommend imaging of the entire spine to look for drop metastases. Back to our mystery case. Look at the restricted diffusion and the origin from the fourth ventricular floor. This was a classic ependymoma. If you got it right, well done. If not, remember the roof versus floor rule. I hope this helps you in your next shift. Don't forget to subscribe for more high-yield radiology lectures. Welcome back. Today, we have a diagnostic challenge that every radiology resident must master. Look at this 6-year-old child presenting with ataxia and signs of increased intracranial pressure. We see a large, heterogeneously enhancing mass centered in the fourth ventricle. Before we dive into the lecture, I want you to look closely at the growth pattern. Is it arising from the roof or the floor? Is it squeezing through the foramina? Pause the video and leave your initial diagnosis in the comments: medulloblastoma or ependymoma. Let's break down the big two. While both occur in the fourth ventricle, their personalities on imaging are very different. Location. Medulloblastoma typically arises from the roof of the fourth ventricle, the superior medullary velum, whereas ependymoma usually arises from the floor. This is your first major clue. Diffusion, the secret weapon. Medulloblastomas are highly cellular. This means you will almost always see restricted diffusion, bright on DWI, dark on ADC. Ependymomas are generally less cellular and won't show that same degree of restriction. Calcification. If you see prominent calcification on CT or susceptibility-weighted imaging, think ependymoma. It's much more common there, about 50%, than in medulloblastoma. It's not always a two-horse race. We must consider the mimics. Juvenile pilocytic astrocytoma, JPA. Look for the classic cyst with an enhancing mural nodule. Unlike our mystery case, JPA is usually more lateral in the cerebellar hemisphere and lacks restricted diffusion. ATRT. This is the aggressive cousin. If the patient is very young, usually under 3 years old, and the tumor looks like a medulloblastoma but is even more heterogeneous with eccentric cysts, you must consider atypical teratoid/rhabdoid tumor. Here are your clinical pearls for the report. The plastic sign. Ependymomas are soft tumors. They don't just grow, they mold and squeeze through the foramina of Luschka and Magendie. If you see tumor extending into the cerebellopontine angle, it's almost certainly an ependymoma. Surgical planning. Always tell your neurosurgeon if the tumor is attached to the floor of the fourth ventricle. That's where the cranial nerve nuclei sit, making total resection much more dangerous. The spine. Never forget, if you suspect medulloblastoma, you must recommend imaging of the entire spine to look for drop metastases. Back to our mystery case. Look at the restricted diffusion and the origin from the fourth ventricular floor. This was a classic ependymoma. If you got it right, well done. If not, remember the roof versus floor rule. I hope this helps you in your next shift. Don't forget to subscribe for more high-yield radiology lectures.
We can summarize lung fibrosis in the following steps. First of all, search for ground glass pattern opacities, which should be peripheral in distribution. Secondly, search for reticulation, which is the early sign of fibrosis, putting in consideration that missing this stage means missing early diagnosis. Late in the disease, honeycombing is noted, which is the late sign of lung fibrosis. The real skill in radiology is catching interstitial lung disease when the signs is subtle before its transformation into lung fibrosis. One of the biggest mistakes is waiting for honeycombing to diagnose lung fibrosis. By then the disease is advanced. The real skill in radiology is catching interstitial lung fibrosis early when the signs is subtle. From the previous slide, the first sign to search in interstitial lung disease is ground glass pattern. If you find it, try secondly to search for reticulation, because if it is present, this is a red flag for early sign of fibrosis, dual sign of diffuse interstitial lung fibrosis. If reticulation is not present, look for other causes of ground glass pattern such as interstitial edema or pneumonia and so on. If honeycombing is present, this is the second red flag, as it gives bad impression that the case is in the late stage of pulmonary fibrosis disease, triple sign of diffuse interstitial lung fibrosis. The ground glass pattern, which is usually seen early in any type of interstitial lung disease, don't just mention it, but interpret its type. If it is diffuse in pattern, suggests inflammation in origin. If it shows peripheral distribution, this appearance raises suspicious of early fibrosis. Finally, if T is patchy in pattern, diagnosis is hypersensitivity pneumonitis. From the previous slide, the first sign to search in interstitial lung disease is ground glass pattern. If you find it, try secondly to search for reticulation, because if it is present, this is a red flag for early sign of fibrosis, dual sign of diffuse interstitial lung fibrosis. If reticulation is not present, look for other causes of ground glass pattern such as interstitial edema or pneumonia and so on. If honeycombing is present, this is the second red flag, as it gives bad impression that the case is in the late stage of pulmonary fibrosis disease, triple sign of diffuse interstitial lung fibrosis. Regarding interstitial lung disease, distribution of the lung is everything. The lungs are telling a story. Your job is to read the map. If interstitial lung disease is basal and subpleural, it will be usual interstitial pneumonia. And if it is in the upper lobes, it will be either sarcoid or hypersensitivity pneumonitis. Lastly, if it is in a peribronchovascular distribution, it will be non-specific interstitial pneumonia. One of the biggest mistakes is waiting for honeycombing to diagnose lung fibrosis. By then the disease is advanced. The real skill in radiology is catching interstitial lung fibrosis early when the signs is subtle. This is where radiology truly makes a difference. Early detection can change everything. It guide treatment, cause slow progression, preserve lung function. We can summarize lung fibrosis in the following steps. First of all, search for ground glass pattern opacities, which should be peripheral in distribution. Secondly, search for reticulation, which is the early sign of fibrosis, putting in consideration that missing this stage means missing early diagnosis. Late in the disease, honeycombing is noted, which is the late sign of lung fibrosis. The real skill in radiology is catching interstitial lung disease when the signs is subtle before its transformation into lung fibrosis. A 19-year-old runner walks into your clinic. Localized tibia pain. It's worse at night, but she tells you it disappears completely with a single aspirin. You look at the CT. There's massive cortical thickening. You think, stress fracture. But if you stop there, you've just missed a bone tumor in disguise. The Nidus Secret. Welcome back to AI Radiology Lectures by Dr. Muhammad El-Masri. Today, we are tackling the deadly twins, osteoid osteoma and stress fracture. On a standard X-ray, they can look identical. But the secret is in the CT. Look closely at this station. See that small lucent area with the central calcified dot? That is the nidus. A stress fracture will never show you this. Key aspects of cortical thickening and associated conditions. Osteoid osteoma, OO, often causes significant sclerosis, dense bone, and cortical thickening, hyperostosis, around a central, small, less than 1.5 centimeters, vascularized area known as the nidus. The tumor secretes high levels of prostaglandins, causing pain that is often worse at night and relieved by NSAIDs. Stress fracture. causes cortical thickening as the body attempts to reinforce the bone due to repetitive stress, often characterized by a gray cortex sign in early stages on X-ray. Diagnostic differentiation. While both can cause massive cortical thickening, a CT scan is typically the best imaging modality to identify the lytic nidus of an osteoid osteoma, which differentiates it from a stress fracture. Case overlap. A stress fracture can sometimes act as a trigger for the formation of a post-traumatic osteoid osteoma, making diagnosis challenging if the pain persists after immobilization. Treatment. While osteoid osteomas can sometimes be managed with long-term NSAIDs, symptomatic cases are often treated with minimally invasive CT-guided radiofrequency ablation. Common clinical similarities. Location. Both are common in the diaphyses of long bones, tibia, femur. Symptoms. Both can present with pain, swelling, and sometimes limping, in children. Imaging. Both can present with intense tracer uptake on bone scans and reactive edema on MRI. Clinical clues. It isn't just about the scan, it's about the story. If the pain is relieved by aspirin within 20 minutes, your suspicion for osteoid osteoma should skyrocket. Getting this wrong means the difference between months of unnecessary rest and a targeted radiofrequency ablation that cures the pain instantly. Let's look at how to report these findings so your orthopedic team knows exactly what to do next. It's the moment every clinician fears and every patient dreads. A routine lung check for cough or maybe a follow-up on a nodule, but the CT scan shows something else. Large, swollen mediastinal lymph nodes. The immediate thought? Cancer. The reality? Often more complicated. Today, we are diving into the detective work of mediastinal lymphadenopathy. Is it cancer, or is it trying to tell us something else? CT atlas of thoracic lymph node stations, with ambiguous regions designated. Number 1 prevascular. Number 2 paraortic. Number 3 retrocaval. Number 4 paraortic. Number 5 subaortic. Number 6 retrotracheal. Number 7 paratracheal. Lastly number 8 left hilar region. Number 9 right hilar region. These nodes are the central hub for lymphatic drainage from the lungs. When the lungs are angry, infection, inflammation, or malignancy, these nodes act as the silent messengers. But which message are they sending? The story of Benign, the chameleon. Meet Sarah, 35. Dry cough, fatigue. CT shows symmetrical, potato-like hilar nodes. It's not lung cancer. This, my friends, is classic sarcoidosis. It's a granulomatous disease that mimics malignancy, yet it's entirely different. Other suspects here? Tuberculosis, histoplasmosis, or pneumoconiosis. The story of Malignant, the Invader. Now meet Robert. 62, smoker. His nodes are irregular, asymmetric, and may be showing necrosis. This is when we move toward non-small cell lung cancer or lymphoma. The key here is not just size, but morphology. Necrotic nodes are high risk. So, how do we distinguish between them? CT is our first clue. PET CT helps with metabolism, but the gold standard? Abscess. Endobronchial ultrasound gives us a tissue diagnosis from those specific stations without opening the chest. Abscess, endobronchial ultrasound-guided transbronchial needle aspiration, involves a specialized bronchoscope with an ultrasound probe at its tip, enabling real-time visualization of mediastinal and hilar lymph nodes. The procedure allows precise needle placement for tissue sampling. Finally, this smart art shows differential diagnosis of mediastinal lymphadenopathy in relation to lung diseases. In case of mediastinal lymphadenopathy plus diffuse reticular lung pattern, diagnosis is between sarcoid or lymphangitic carcinomatosis. In case of mediastinal lymphadenopathy plus diffuse alveolar lung pattern, diagnosis is between alveolar cell carcinoma or alveolar infection. In case of mediastinal lymphadenopathy plus diffuse nodular lung pattern, diagnosis is pneumoconiosis. In case of mediastinal lymphadenopathy plus diffuse cystic lung pattern, diagnosis is between lymphocytic interstitial pneumonia or lymphangiomyomatosis. Finally, in case of focal lung disease, it could be bronchogenic carcinoma or metastases. Mediastinal nodes are the ultimate puzzle in chest medicine. Don't let your first impression be your only impression. If you found this case study helpful, make sure to like and subscribe for more deep dives into radiology and pulmonology.